This is the mental health exam 2. Both delirium and dementia patients can exhibit signs of confusion, anxiety, agitation, and disorganized thoughts. Delirium is most frequent complication of hospitalization in older adults. Delirium medications: antipsychotic low-dose haloperidol, which is Haldol. Benzodiazepines are commonly used if etiology is substance withdrawal, lorazepam, ADN or diazepam, Valium. B1 IV for thiamine deficiency. Supplemental oxygen. 4 cardinal symptoms and features of delirium: acute onset and fluctuating course, reduced ability to direct, focus, shift, and sustain attention, disorganized thinking, and disturbance of consciousness. Acute onset and fluctuating levels of awareness are key findings in delirium. Evaluate the person's current level of cognitive and daily functioning. Identify any threats to the person's safety and security and arrange their reduction. Evaluate the safety of the person's home environment. Review their medications, including herbs, complementary agents the patient is currently taking. Interview family members to gain a complete picture of the person's background and personality. Explore how well the family is prepared for and informed about the progress of the person's dementia, depending on the cause, if known. Discuss with family members how they are coping with the patient and their main issues at this time. Review the resources available to the family. Ask family members to describe the help they receive from other family members. Determine whether caregivers are aware of community support groups and resources. Identify the needs of the family for teaching and guidance. How to manage catastrophic reactions, liability of mood, aggressive behaviors, and nocturnal delirium, and increased confusion and agitation at night, what is considered sundowning. Validation therapy. It is vital that when the individual is saying is heard, and that the caregiver listens and understands the frustration shown. Substance use and addictive disorders. They start out as a disease of choice but end as a complex disease of the brain characterized by craving, seeking, and use regardless of the price they may pay. Substance use complications: intoxication. Excessive use of substance symptoms vary with substance used. Tolerance occurs when a person no longer responds to the drug in the way that he or she initially responded. Withdrawal occurs upon reduction or discontinuation of substance that has been used regularly over a long period of time. Medications for alcohol withdrawal: diazepam or Valium relieves acute agitation, tremor, impending delirium tremens, and hallucination. Chlorodiazepoxide or Librium used to reduce the danger of progressing delirium. Once the delirium appears, intravenous lorazepam or Ativan is used to treat severe symptoms. Withdrawal timeline: 6 to 12 hours after last drink. Mild anxiety, insomnia, and upset stomach. Within 24 hours, this is visual, sudatory, and tactile hallucinations. And between 24 to 72 hours, withdrawal and delirium tremens and seizures. Delirium tremens is an autonomic hyperactivity. This is tachycardia, diaphoresis, fever, and anxiety, common in alcohol withdrawal. Medications to assist in preventing relapse. This is disulfiram for alcohol. Any exposure to alcohol while taking this medication leads to violent NV. Naltrexone, this is Vivitrol for alcohol and opiates. It blocks euphoria, the high, and craving. Buprenorphine or naloxone, which is Suboxone for opiates. Naloxone is Narcan for opiates, used in overdose situations and can be used long-term orally. Methadone for opiates. It blocks the high. Pupils are usually constricted after the use of opioid narcotics. Codependence is a cluster of behaviors originally identified through research involving the families of alcoholic patients. People who are codependent often exhibit over-responsible behavior, doing for others what others could just as well do for themselves. Alcohol withdrawal delirium may happen anytime in the first 72 hours. Autonomic hyperactivity may result in tachycardia, diaphoresis, fever, anxiety, insomnia, and hypertension. Delusions and visual and tactile hallucinations are common in alcohol withdrawal delirium. Positive symptoms. These are highly exaggerated ideas, perception, or actions that show the person can't tell what's real from what isn't. Here the word positive means the presence, rather than absence, of symptoms. They can include hallucinations. People with schizophrenia might hear, see, smell, or feel things no one else does. The type of hallucinations in schizophrenia include auditory. The person most often hears voices in their head. Visual. Someone might see lights, objects, people, or patterns. Often it's loved ones or friends who are no longer alive. Olfactory and gustatory. This can include good and bad smells and tastes. Someone might believe they're being poisoned and refuse to eat. Tactile. This creates a feeling of things moving on your body, like hands or insects, paranoia, neologism, and echolalia. Command are auditory hallucinations that instruct a patient to act in specific ways. These commands can range in seriousness from innocuous to life-threatening. Delusions. These are beliefs that seem strange to most people and are easy to prove wrong. Types of delusions include persecutory delusions, the feeling someone is after you or that you are feeling stalked, hunted, framed, or tricked. Referential delusions, when a person believes that public forms of communication like song lyrics or a gesture from a TV host are special messages just for them. Somatic delusions. These center on the body. The person thinks they have a terrible illness or bizarre health problem like worms under the skin or damage from cosmic rays. Erotomanic delusions. A person might be convinced a celebrity is in love with them or that their partner is cheating, or they might think people they're not attracted to are pursuing them. Religious delusions. Someone might think they have a special relationship with a deity or that possessed by a demon. Grandiose illusions. They consider themselves a major figure on the world stage, like an entertainer or a politician. Confused thoughts and disorganized speech. People with schizophrenia can have hard time organizing their thoughts. They might not be able to follow along when you talk to them. Instead, it might seem like they're zoning out or distracted. Trouble concentrating. For example, someone might lose track of what's going on in a TV show as they're watching. Movement disorders. Some people with schizophrenia can seem jumpy or catatonic. Negative symptoms. Negative symptoms of schizophrenia is an absence or lack of normal mental function involving thinking, behavior, and perception. You might notice lack of pleasure. The person may not seem to enjoy anything anymore. A doctor will call this anhedonia. Trouble with speech. They might not talk much or show any feelings. Doctors call this allogia. Flattening. The person with schizophrenia might seem like they have a terrible case of the blahs. Withdrawal. This might include no longer making plans with friends or becoming a hermit. Talking to the person can feel like pulling teeth. Doctors call this apathy. Struggling with the basics of daily life. They may stop bathing or taking care of themselves. No follow-through. A doctor might call this avolition. Depression is an emotional swings between highs and lows. Cognitive symptoms and thinking problems reflect how well the person's brain learns, stores, and uses information. The dopaminergic system widely implicated in the etiology of schizophrenia. Early onset is being observed in children and young adults. It is usually being seen in the 18 to 20 age group. Clients with personality disorders have increased risk for psychotic disorders. Deafness can contribute to psychotic disorders. Some antihistamines can cause psychotic disorders. Excessive or with severe withdrawal symptoms can cause substance-induced psychotic disorders. Genetics is becoming more discussed as a possible factor for psychotic disorders. The latest research is focusing on the eye-brain pathways. The actual cause of schizophrenia remains controversial. Predominal phase withdrawing, misinterpreting, poor concentration, and preoccupation with religion. Client has impaired role function and neglect of personal hygiene. Premorbid phase, the patient is withdrawn. Schizophrenia. Schizophreniform disorder is the essential features are identical to those of schizophrenia, but of shorter duration, less than 6 months. Schizoaffective disorder is a combination of symptoms of schizophrenia and mood disorder, such as depression or bipolar disorder. Symptoms may occur at the same time or at different times. Delusional disorder is characterized by one or more firmly held false beliefs that persist for at least 1 month. Major symptoms of schizophrenia. Anhedonia is the inability to feel pleasure. Social withdrawal, diminished pleasure derived from daily activities, a lack of relationships or withdrawal from previous relationships, less of an interest in previous hobbies, a loss of libido or a lack of intense interest in physical intimacy, increased risk for suicide. Hallucinations, when a person sees, hears, smells, tastes, or feels things that are not actually there. Delusions, when a person has strong beliefs that are not true and may seem irrational to others. Thought disorder, when a person has ways of thinking that are unusual or illogical. They can revert to childlike behaviors and temper tantrums. These are using regression to reduce anxiety. Catatonia is significant motor disturbance. Catalepsy is when a person holds a position in which someone places them. Posturing. This is when a person holds a specific position which would often be uncomfortable to people who aren't experienced catatonia. This doesn't involve being placed in a position by another person. Waxy flexibility. This is when a person puts up some slight, even pushback or resistance to any attempt to change their position. Then their muscles slowly release and their limbs bend like a warm candle. Stereotypy. These are repetitive movements that don't seem to have a purpose. Stupor. This is when a person is awake but doesn't respond to what's happening around them. People with catatonia often don't respond to painful stimuli, such as being pinched. If a paranoid client is refusing medications, ask them what it is about the medications that they don't like. If the client has an increase in pacing and hallucinations, this might indicate the client is not tolerating the stimulation on the unit well. Should a client be notified as not sleeping when they are in a joint room, this could be due to the client being suspicious of their roommate. If a client is observed sitting on the floor looking underneath the bed and having a conversation, this is hallucinating. Communication guidelines. Tangential thinking. Suggest an activity to the client and they respond by telling you how active they are at home and detail their volunteer activities. Reverential thinking. The TV is speaking to them. Magical thinking. Magical thinking or superstitious thinking. This is the belief that unrelated events are causally connected despite the absence of any plausible causal link. Step on cracks in the pavement will cause a bad luck or injury to others. Delusion of influence. The heart monitor is controlling my thoughts. The new hip joint is controlling my thoughts. All client relationships should be non-demanding in nature. The primary goal is to establish clear and consistent open communication, present reality in clear, simple language, and demonstrate patience. Echolalia. People with echolalia repeat noises and phrases that they hear. Neologism. Newly coined word or expression. This is typically associated with aphasia or schizophrenia. Flat affect. No emotional expression. First-generational antipsychotics, also known as neuroleptics, conventional or typical antipsychotics, have significant potential to cause extrapyramidal symptoms and tardive dyskinesia. First-generation antipsychotics include chlorpromazine, droperidol, fluphenazine, haloperidol, loxapine, parafenazine, pimazide, prochlorperazine, fluoridazine, thiazine, trifluoperazine. Second generation for monotherapy is aripiprazole, acinapine, clozapine, iliperidone, lurasidone, olanzapine, paliperidone, quintiapine, risperidone, and ziprasidone. Combination therapy is olanzapine plus fluoxetine. Side effects of antipsychotics include constipation, higher risk of diabetes, restlessness, sexual problems, sleepiness, uncontrolled movement or shakiness in your jaw, lips, and tongue, called tardive dyskinesia. FGA first-generation side effects. One of the most significant side effects of FGA is movement problems. Side effects include muscle stiffness, dystonia, tardive dyskinesia. Dystonia is muscle contract involuntarily and cause repetitive or twisting movements. Tardive dyskinesia involves uncontrollable movement or shakiness in your jaw, lips, and tongue. Chlorpromazine is a phenothiazine neuroleptic, antipsychotic agent. Pain and irritation at site of injection. Sedation, which is tolerance, develops rapidly. Convulsions is rarely. Tachycardia, ECG changes, hypotension, and cardiac arrhythmias. Gastrointestinal is constipation, jaundice, photosensitivity, EPS, and TD. Akaphasia, can't stand still, pacing, and agitated. Quetiapine tablets and extended release, long-acting tablets are used to treat the symptoms of schizophrenia. Difficulty thinking or concentrating, decreased sexual desire or ability, and fever is 911. Haloperidol is a first-generation atypical antipsychotic. It's commonly used worldwide to block dopamine. The medication is used to manage the positive symptoms of schizophrenia, including hallucinations and delusions. The adverse effect is tardive dyskinesia. Olanzapine helps to manage symptoms of mental health conditions such as seeing, hearing, feeling, or believing things that others do not. Tricyclic antidepressants, or TCAs, constitute a class of medications used to manage and treat major depressive disorders, MDD. Tricyclics drugs are known to be used in patients' overdose cases. Benztropine is used to treat symptoms of Parkinson's disease or involuntary movements due to the side effects of certain psychiatric drugs, antipsychotics such as chlorpromazine and haloperidol. Risperidone treats schizophrenia, bipolar disorder, and autism spectrum disorder. It works by balancing the levels of dopamine and serotonin in your brain. Increased fluid and fiber on patients taking this medication. The side effects include feeling sleepy in the day or difficulty falling asleep at night. Problems with your movement, difficulty moving, stiff muscles with movements, which are difficult to control, a slow shuffling walk, shakes and drooling. This is known as dyskinesia. Headaches, putting on weight, or changes in appetite. Fluphenazine is an antipsychotic medication used to treat schizophrenia and psychotic symptoms such as hallucination, delusions, and hostility. This is also used for pseudo-Parkinson's. Bipolar disorder. Bipolar I is characterized by mood swings from severe depression to extreme euphoria, mania. When in the manic phase, clients usually need hospitalization. If lithium levels are 1.9, notify doc and hold. Hydration is important to keep sodium-lithium balance. Anything that interferes with that, like diarrhea, severe vomiting, can put the patient at risk for lithium toxicity. Deep brain stimulation, or DBS. This is implanting electrodes within certain areas of the brain. These electrodes produce electrical impulses that regulate abnormal impulses, used usually for Parkinson's and OCD. Nursing management of milieu. Nutritional risk provides nutritious finger foods. Structure solitary activities or activities that can release energy, like walking, playing cornhole, etc. Ask about suicidal ideations is the most important assessment the nurse can make to determine suicidal intent. Risk for serotonin syndrome when taking antidepressants and certain herbal use, such as St. John wort. SSRIs and SNRIs increase appetite. Watch for changes in mood if suddenly happy when had been depressed, may have worked out a suicide plan. In talking with the patient, discharge planning at admission needs to determine if the patient has lethal means at home. The difference between MDD, major depressive disorder, and PDD, persistent depressive disorder, is the severity of symptoms. In MDD, they may not be able to do ADLs. PDD also is almost always with you. MDD can be severe but tends to resolve itself over time with therapy and medication. Depression with psychotic features is serious because of suicidal risk, as with all depressions, and self-harm or harm to others from the psychosis. Bulimia is a serious eating disorder. People with this have episodes of binge eating followed by purging. The purging type of the disease involves the vomiting, plus the exercise and laxatives. The non-purging does not include the vomiting, but abuse of laxatives and excessive exercise is seen. The cycle of binging and purging tend to dominate daily life and can have a negative impact on the well-being of the individual. Okay, so here's some questions and answers from Cahoots. Shortly before treatment, after crying and begging him to get help, Ahmed's girlfriend stayed home from a planned night out with her friends to pour all the alcohol in his apartment down the drain. What type of behavior is evident? This is codependence. A nurse is assigned the care of 4 patients who are detoxifying from alcohol. The patient with which symptom would be the nurse's highest priority? Hallucinations and delusions. A person has recently abused morphine. The person's pupils would most likely be constricted. Which is an indication that Veronica does not have delirium? Her problems with memory have been developing gradually. Veronica tries to refer to the electric bill, but ends up saying, "You know the invitation, what is this a sign of?" This is aphasia. It's the loss of language ability. I sound like I have aphasia. Acute onset of disordered thinking is most associated with delirium. Decreased ability to recognize sounds is auditory agnosia. True or false? Dementia has an abrupt onset with reduced orientation to the environment and self. False. Which is not a symptom of dementia? Pseudo-dementia. Which statement about Alzheimer's is not true? After 2 weeks of medication, the patient will be cured. Patients at highest risk for delirium are people older than 65. True or false? Patients with Alzheimer's and dementia should have fall risk precautions. True. Which is not a nursing measure for dementia? Private room. True or false? The usual duration of delirium can be at least 3 months. False. True or false? The onset of delirium is abrupt. True. What is the decreased ability to speak? Aphasia. What is the assessment used to determine cognition? MSE. What is the patient makes up works for objects? Neologisms. What is the total inability to perform ADLs in the stage of Alzheimer's? This is stage 7. What is the phobia? Phobia is the type of this disorder. Anxiety. In stage 4 dementia, the nurse should be doing every 2-hour turns on patient. False. Nursing diagnosis. Self-care deficiency related to disease process is appropriate for dementia. True. Expected outcome for delirium. Returns to pre-hospitalization cognitive functioning level. True or false? Alzheimer's can be cured with medication. False. True or false? In stage 7 of dementia, the patient cannot recognize family and is bedbound. True. True or false? Patients with delirium commonly sleep through the night. False. Alzheimer's brain changes include all but frontal lobe growth. Confabulation is more likely to present with dementia. Dementia mainly affects cognitive function and memory. True or false? Memantine is used for delirium. False. Which med is not for Alzheimer's disease? This is L-tryptophan. Delirium can be caused by all but chronic pain. Alzheimer's patients unable to do ADLs with fear of being alone is in stage 6 and 7. True or false? Delirium can have periods of hypervigilance and decreased level of consciousness. This is true. Key safety measures for Alzheimer's include all but keep the patient restrained in a locked secured room. Expected outcomes of delirium include return to previous cognitive functioning. Illness with reduced ability to comprehend reality is schizophrenia. Ongoing and intense fear of abandonment is BPD. Trauma-informed care communication approach. What happened to you? Lithium is given for this disorder, bipolar 1. Psychotherapy is the primary treatment for BPD. A nurse dislikes a patient who reminds her of an ex-spouse in a bad relationship. This is countertransference. Condition with psychosis and mood disorder. This is schizoaffective. Hallucinations are positive symptoms. Setting consistent boundaries and expectations is important with this type of patient, BPD. You must have a manic episode for this diagnosis, bipolar 1. True or false? Having one psychotic break means you are schizophrenic. False. True or false? Patients who are bipolar 2 always need hospitalization. False. Patient falls in love with a nurse who takes care of him on the unit. This is an example of transference. Condition with chaining of one worry leading to another trouble sleeping is GADs. Symptoms start in adolescence to early 20s may include delusions and hallucinations. This is schizophrenia. Broad opening therapeutic communication statement. What would you like to talk about? True or false? Anhedonia is another word for pleasure. False. During the first few weeks, patients started on antidepressants are at risk for suicide. Frequent metabolic panel labs are required during summer for the use of this medication. Lithium. Withdrawing from this substance can cause seizures. Valium.